Good afternoon, friends. This is teleconferencing program, and this program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. This program is based on 5 sessions, and this program is specially designed for DNB students. If you are a DNB students, you can make a phone call in our studios and ask your queries from our expert. Our expert of today's program is Dr. M.K. Sen, and Dr. M.K. Sen is a senior chest physician in Safdarjung Hospital, New Delhi. Right now, I know that you would like to know the topic of today's program. The topic of today's program was first session is Idiopathic Pulmonary Fibrosis. If you want to ask anything, our phone numbers are for you 29532844 and 29532845. You will have to affix 011 before dialing these two numbers if you are dialing outside Delhi, but you need not to dial 011 before dialing our toll-free number, that is 1800112345. To download the forms of National Board of Examination, you can visit our website, that is www.natboard.edu.in. www.natboard.edu.in. And to get the DVDs of any of our teleconferencing programs, you can contact National Board of Examination. As I have already told you that this program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. So this is the right time to start the first session of our today's program about idiopathic pulmonary fibrosis. Dr. M.K. Sen, please.
Thank you and good afternoon to everyone. In this series of lectures on respiratory medicine last month, we discussed various topics related to interstitial lung diseases. Those were general in nature. This afternoon, we would be taking up several topics which pertain to specific interstitial lung diseases. And the first in this series of today's lectures, we begin with idiopathic pulmonary fibrosis. Pulmonary fibrosis is a specific form of chronic fibrosing interstitial pneumonia which is limited to the lung and is associated with histopathological evidence of UIP pattern or usual interstitial pneumonia pattern on surgical lung biopsy. To label it as idiopathic, it is mandatory for us to exclude the known causes of pulmonary fibrosis like environmental exposures, drug toxicities, and connective tissue disorders. This afternoon, for the next 40 minutes or so, I propose to take you through the major etiological and epidemiological factors of idiopathic pulmonary fibrosis, discuss various aspects of the clinical features and diagnostic modalities, and finally touch upon the management issues and prognostic parameters related to idiopathic pulmonary fibrosis. Any discussion on interstitial lung diseases in general and idiopathic pulmonary fibrosis in particular, it would not be proper to avoid the consensus, all too familiar consensus, American Thoracic Society, European Respiratory Society guidelines, which were provided to us way back in 2002, according to which the interstitial lung diseases are grouped into 4 major categories. We all know the first being the diffuse parenchymal lung diseases of known causes like drugs or connective tissue diseases. The second, those that are idiopathic interstitial pneumonias. The third pertains to the various granulomatous conditions like sarcoidosis. And the last is the other forms of diffuse parenchymal lung diseases like lymphangioliomyomatosis. Now, idiopathic pulmonary fibrosis happens to be of seminal importance not only because of its commonality but also because of its grave prognosis. The other various other modalities that are included in the idiopathic interstitial pneumonia group, as you know, are desquamative interstitial pneumonia, respiratory bronchiolitis with interstitial lung disease, acute interstitial pneumonia, cryptogenic organizing pneumonia, non-specific interstitial pneumonia, and lymphocytic interstitial pneumonia. We also have another recent guideline which has been proposed by the British Thoracic Society in collaboration with the Thoracic Society of Australia, New Zealand, and the Irish Thoracic Society, that was published in the supplement of Thorax Journal dated May 2008, which we are going to touch upon. And we are also told that the next international panel of experts on interstitial lung diseases under the chairmanship of Professor Ganesh Raghu is already at work constructing and updating the next guidelines, and we shall hopefully be having the set of guidelines by the end of this year or early next year. Now, idiopathic pulmonary fibrosis is the most commonly occurring entity amongst the ILDs of unknown etiology. The terms cryptogenic fibrosing alveolitis and idiopathic pulmonary fibrosis describe the same syndrome. The mean age of onset of Indian patients is about 50 years, which is approximately a decade earlier to that in most Western series. The incidence of idiopathic pulmonary fibrosis, or IPF in short, is about 10.7 cases per 100,000 per year for males and 7.4 per 100,000 per year for females. The prevalence happens to be about 20 and 13 respectively for the male and the female genders. The prevalence has been observed to increase with age. With increasing age amongst men and women of more than 75 years of age, the incidence is as high as 160 per 1 lakh, and the prevalence is 250 per 10 to the power 5. It's almost more than 20 times more, or maybe 10 times more than that in the general population. Now, IPF has no predilection for geographical regions or races, and quite often the middle-aged between 50 to 70 years are the ones to present, and 2/3 of the population over 60 years old, 2/3 of the patients who present with IPF happen to be more than 60 years old at presentation. So we know that it is a disease of the middle age at presentation. The male preponderance is about 1:1.7, as we've already seen. The majority happen to be former smokers or current smokers. So the smokers they present earlier, and as we will see in a short while, and the current smokers are younger at age at presentation than those who have never smoked or who have been former smokers. So this slide shows the increased incidence of the increased the age at presentation of IPF happens to be between 50 to 70 years, as you can see in this bar diagram. And this diagram shows you that the presentation, the age of onset at presentation is slightly a notch earlier amongst the current smokers than the group of patients who have been either former smokers or non-smokers. So the current smokers present earlier or younger with the disease. Now, what about the etiopathogenesis? Now, several hypotheses have been put forth. The chronic active inflammation happens to play an important role. There is fibrotic destructive change that distorts the lung architecture, and it results in a high morbidity and mortality. Now, the histopathologic hallmark of IPF happens to be the presence of fibroblastic foci. What are fibroblastic foci? They are small aggregates of actively proliferating myofibroblasts and fibroblasts, which are located within the interstitial space directly beneath the alveolar epithelium. And these are the main sites of ongoing injury and ongoing repair. Here you can see in a microslide 2 foci of active collagen synthesis, here and here, as marked by the arrowheads. And this synthesis is occurring at the edge of a badly distorted area of lung, and the discontinuous remnants of the basal lamina are present beneath the fibroblasts within the lumen of the air space. So one of the models of etiopathogenesis of IPF suggests the initial multiple micro injuries which damage and activate the alveolar epithelial cells lead to the induction of antifibrinolytic environment in the alveolar spaces. Thus, enhancing wound clot formation. This in turn leads the alveolus epithelial cells to secrete various growth factors and induce migration and proliferation of fibroblasts and their differentiation into myofibroblasts. This is a very crucial cell in the pathogenesis of IPF, the myofibroblasts. And the myofibroblasts would produce a lot of gelatinases, which in turn would lead to transmigration of these cells beyond the membranes, and it would also produce a lot of angiogenic factors, which leads ultimately to neovascularization. And what is the end result? The end result is that the myofibroblast would secrete extracellular matrix proteins, and the nature of which happens to be mainly collagen. So there is deposition of collagenous matrix proteins in the air space and the interstitium. Another very important pathogenetic mechanism that has been put forth by a group from the Royal Brompton Hospital in UK highlights that the initial injury actually activates multiple inflammatory cells and cell signaling and repair pathways. So initially there is activation of the coagulation cascade, the antioxidant cascade, the fibrocytes and inflammatory cells, and the Th1 and Th2 immune cascades. So there is an imbalance between the pro-fibrotic mediators and the anti-fibrotic mediators. And eventually there is this epidermal mesenchymal transformation, transdifferentiation, proliferation, and extracellular matrix production, leading ultimately to laying down of a huge amount of fibrotic tissue, excessive extracellular matrix deposition. The imbalance between the interstitial collagenases and the tissue inhibitors of metalloproteinases provokes extracellular progressive deposition of matrix, and it signals for the myofibroblast apoptosis. These are absent. The myofibroblast produces angiotensinogen, which as angiotensin II provokes alveolar epithelial cell death and further impairing reepithelialization. So one can see that on the one hand there is enhancement of the myofibroblast proliferation, leading to excessive laying down of collagen and fibrosis, and on the other there is inhibition of apoptosis of the epithelial group of cells, thus leading to impairment in reepithelialization. What are the clinical findings in idiopathic pulmonary fibrosis? Now, the disease is insidious in onset. One must know that it is often quite late in the day that the disease manifests itself. It has an insidious onset of breathlessness with exertion and a non-productive cough. Quite often it is just a non-productive cough which leads one to look for this condition. Few present with weight loss, fever, fatigue, myalgia, arthralgia, and these constitutional symptoms would suggest the presence of another disease like connective tissue disorders, cryptogenic organizing pneumonias, and infections with viruses and mycoplasma. The median duration prior to diagnosis is as high as 2 years. The physical examination would reveal late inspiratory crackles at the lung bases, which are classically termed as Velcro rals. The higher proportion of current smokers have none or few crackles compared to never or former smokers. Clubbing is a very important manifestation which is present in anywhere between 40 to 75% of the patients, but remember that it may occur late in the disease course. Pulmonary hypertension and cor pulmonale, they occur in the mid to late stages. Cyanosis is a late manifestation. This is classical clubbing, which is manifested as an increase in the diameter of CD as compared to AB, as in this diagram, and the increase or the more obtuse angulation of the angle ACE, that it becomes more than 180 degrees. Now, how does bronchoalveolar lavage help? Now remember that there is no definite correlation between the percentage of various cells or cell types in the bronchoalveolar lavage and the clinical parameters, the serum tests or the pulmonary function tests. However, there is a strong correlation which has been suggested between the percentage of neutrophils in the bronchoalveolar lavage and the prognosis of idiopathic pulmonary fibrosis. The bronchoalveolar lavage eosinophilia remember, is reported to have a poor response to steroids. Now, this is a smear from bowel fluid which shows cells recovered from a normal subject. You can see the cells are mainly pulmonary alveolar macrophages. Now, on the other hand, this is bowel fluid from IPF with increased total number of cells, and the predominant cells happen to be neutrophils. You can see the multi-lobulated nuclei of the neutrophils. And then bowel in progressive interstitial pulmonary fibrosis shows eosinophilia. You can see the spectacle-shaped nuclei of eosinophils present in bowel fluid intermixed with pulmonary alveolar macrophages. So the presence of eosinophils and neutrophils in bowel fluid has been, as we've just seen, associated with a poorer prognosis. Now, another important aspect is the presence of phospholipids. The various phospholipids like dipalmitoyl phosphatidylcholine, phosphatidylglycerol and phosphatidyinositol, they are all very important components of the cellular membranes. In IPF, the changes in the ratio of phosphatidylglycerol to phosphatidylinositol are predictive of cellularity and the degree of fibrosis on histopathological examination of open lung biopsies. Patients with a high level of phosphatidylinositol in the bowel fluid have been shown to improve with steroid therapy. Now, this is the relationship between the ratio of surfactant protein A to phospholipids. The mean ratio of surfactant protein A to phospholipids was lower in one study in patients with IPF than in healthy volunteers, and in patients who died in 2 years than in those who survived. On the left panel, you find the higher ratio present in those who survived, and on the right, you find the ratio being lower in patients with IPF who expired. Now, another important parameter is the serum levels of surfactant protein A and surfactant protein D. The levels are elevated in patients with IPF and progressive systemic sclerosis, and are they not elevated in other pulmonary diseases with less diffuse parenchymal involvement. So, the serum SPA and the serum surfactant protein D levels are highly predictive of survival in IPF patients. Coming to the pulmonary physiology and airway mechanics, these patients are generally tachypnic, they demonstrate rapid shallow breathing, they have an increased work of breathing. The increased respiratory rate is generally secondary to altered mechanical reflexes, as evidenced by an increase in the elastic load and or the vagal mechanisms. The forced expiratory volume in 1 second and the forced vital capacity are decreased, but the ratio of FEV1 to FVC is well maintained. And because of the increased static elastic recoil, the flow rates often, when compared to lung volumes, are increased. Here we find that the FEV1 and the FVC are low, but the ratio is increased. It's about 83%. However, at any given lung volume, the flow rates are increased. These changes are more evident after follow-up or after treatment. The lung volumes, total lung capacity, functional residual capacity, and residual volume are reduced at some point in the course of most patients with IPF. Early on, more commonly in patients with COPD, lung volumes may often be normal. Lung volumes are higher in current smokers at presentation as compared to never smokers in IPF. Now, you find here that the never smokers with IPF have a significantly higher ratio of FEV1 to FVC than former smokers. The top panel here refers to the current smokers, and the middle and the lower panels refer to the former smokers and the never smokers. Again, you find that the TLC was significantly lower in former smokers and never smokers when compared to the current smokers represented by the top panel in IPF patients. Now, there is a downward and the rightward shift of the pressure volume curve. If we see the pressure volume curve, the beak tends to turn downward and rightward as the stiffness or the compliance of the lung decreases and the stiffness of the lung increases. The coefficient of elastic retraction was significantly higher in the never and former smokers than in the current smokers. What happens to the gas exchange? Now, exercise physiology tells us that the DLCO is reduced due to a reduction in the pulmonary capillary volume and the ventilation perfusion abnormalities, and it may actually precede the reduction in lung volumes. So, it is a very sensitive parameter. the initial resting arterial blood gas value may be normal, or it may reveal just a mild hypoxemia with respiratory alkalosis. But with exercise, the alveolar arteriolar oxygen gradient has been seen to widen, and the partial pressure of oxygen in the arterial blood drops. Exercise testing thus is a more sensitive than resting physiological testing, and exercise gas exchange is a sensitive parameter for following the clinical course. Patients with IPF have elevated minute ventilation during exercise, that is in part related to the increase in dead space ventilation. The VD-VT ratio is increased at rest, however it is maintained or decreased with exercise. So in any patients of IPF, if there is an increase in the VD-VT ratio with exercise, it should raise the doubt of either a pulmonary vascular disease, especially chronic pulmonary embolism or associated emphysema. What happens to pulmonary hemodynamics? Pulmonary hypertension rarely occurs at rest in patients with early IPF, and cor pulmonale is a late sequel. The various causes of pulmonary hypertension in IPF include primary lesion of the pulmonary vessels, compression and destruction of the pulmonary vessels by interstitial processes, vasoconstriction of vessels mediated by hypoxia, acidosis, and autocoids. Various other factors like pulmonary blood volume and pulmonary arterial compliance also may be responsible. It has been demonstrated that oxygen therapy during exercise and at rest improves pulmonary hemodynamics, and likely improves exercise capacity and prognosis. Very little data, however, exists on the role of vasodilator therapy in the treatment of pulmonary hypertension. Chest radiography. Most commonly, reticular shadows or net-like appearance of linear or curvilinear densities, which happen to be diffuse and have a predilection for the lower zones, are seen on a chest X-ray. A coarse reticular pattern and or multiple cystic or honeycombed areas, that is coarse reticular pattern with translucencies measuring half to 1 centimeter diameter, is a late radiographic finding and portends a very poor prognosis. Reduced lung volume is usually present unless there is associated COPD. The correlation between chest radiography and clinical stage of disease is poor. Pleural involvement is extremely rare and suggests other conditions like ILD with collagen connective tissue disease, mitral valve disease, congestive heart failure, asbestosis, and lymphatic carcinomatosis. This is an X-ray from a patient which shows coarse reticular opacities in the mid to late stages of pulmonary fibrosis. Another patient with COPD, and please note the hyperexpanded lung fields in this patient. He has a comorbid COPD. This is long-standing IPF with severe radiographic honeycombing seen mainly in the mid and lower zones. What about the high-resolution CT? The high-resolution CT in IPF shows bilateral, predominantly basal, subpleural distribution of reticular pattern associated with subpleural cysts or honeycombing with traction bronchiectasis. Consolidation and nodules are characteristically absent, and the presence of ground glass opacity may be associated with any of the following on histopathology, that is interstitial inflammation, airspace filling by macrophages, patchy fibrosis, or a combination of these features. So ground glass opacity need not always suggest an inflammation. It may also represent fibrosis. Reticular opacities tend to correlate with fibrosis. Honeycomb cysts in the end-stage disease represent dilated bronchioles that communicate with the proximal airways and are seen to change in size with respiration. Patients with predominant reticular or honeycombing usually progress despite treatment. A multidisciplinary approach, therefore, remains the gold standard of diagnosis. This is an HRCT scan which shows reticular and honeycomb patterns, subpleural lesions distribution in late IPF. Now on the left panel you have an initial CT which shows ground glass pattern involving the lower zone. On follow-up on the right panel